The last section that we're going to discuss in pulmonary diagnostics is cardiopulmonary exercise testing. Now, this is similar to what some of you have seen as what we call a cardiac stress test, except that we are not just looking at how well the heart performs, but we're also looking at how well the respiratory system and the lungs perform in bringing in fresh oxygen and the production of carbon dioxide. We basically will be measuring the efficiency of the entire cardiopulmonary system, not just the heart, during exercise, and then we compare it to what that person is doing at rest. In this way, it can kind of guide us as to whether or not somebody has a reserve for certain levels of exercise. When you're dealing with COPDers who reach that limiting state, we can kind of find out what is their reserve. Should they be eligible for pulmonary rehab? Do they have the cardiac function for cardiopulmonary rehab, etc.? It can also tell us if some of the problem isn't that they have disease per se, but deconditioning being part of their problem, and you can measure that. Even athletes will sometimes have their physicians do this so they can look at what their reserves are. How do we accomplish this? We can do it several different ways. You can use a regular walking treadmill. In a lot of PFT labs, they actually use the bicycle ergometer. And the reason why they use the ergometer is because you're sitting stationary and just pedaling rather than trying to physically walk with all the wires and stuff, and the risk of them getting tangled up in your feet. And then you've got headgear on your mouth. You're actually breathing in the system and a mouthpiece, and there's just a lot of pieces that are involved in it. You can also do walking or using steps and stuff, but the most common thing you're going to see in a true cardiopulmonary stress test is going to be the cycle ergometer. As we're monitoring these patients, we are obviously looking at their heart rate, and just like any other treadmill that you might see done for a cardiac stress test, we're wanting to stress the heart and thus the lungs to a certain point, and we target a percentage of the max heart rate. You determine your max heart rate by taking 220 minus your age, and that tells you what the maximum heart rate should be. So if you're 20 years old and you take 220 minus the age, the maximum heart rate that's safe that your heart should be able to pump relatively effectively is 200 beats per minute. Now, our goal is not necessarily to get us to that max point, but in order for there to be a good test and find out whether the heart was stressed enough and the lungs were stressed enough, we want to see somebody's heart rate get to at least 85% of this predicted range. So, 85% of 200 is a heart rate of 170. So if you can get a heart rate of 170 or above, then it can be considered a good test. We do want to be able to look at various things as we're doing the test. First of all, what is their ECG rhythm? Is it a normal sinus rhythm? Do they have any ST depressions, meaning they have some myocardial ischemia? Do they have ectopy? As you're exercising them, are you causing a lot of PVCs? Are they multifocal, unifocal, bigiminy, trigiminy, quadgiminy, etc.? So another reason why you would want to know how to interpret the basics of EKGs. A key thing, the last EKG rhythm is on the bottom right, is artifact. A challenge when you're doing exercise stress testing is to make sure that you're prepping your patients appropriately. You've got to break down any barriers between the gel medium and the skin. You got to scrub it. Actually some places will use sandpaper. You want to make sure you have good tight contact, etc. As you can see on that one on the bottom right, that is a great deal of artifact. And if you have that, you're not going to be able to determine whether or not you have PVCs or ST segment depressions, etc. So, when we're doing cardiopulmonary stress tests, just like regular stress tests, we also want to monitor their blood pressure. Now, this picture shows you an art line, and it's measuring invasively, and it's probably the most accurate and easiest of all. But I can tell you that I have never done a cardiopulmonary stress test where we put an art line in. definitely for research, most assuredly for research, you would probably want to have that, because otherwise, as they're exercising, you as a clinician are actually taking the blood pressure manually, just like you would on anybody else. And when you have a lot of movement and you have the arms moving and noise from the machine, etc., it can be a little bit harder to do. But I've done it many times with a good stethoscope and not had too many issues. You want to, normally you're going to see your blood pressure go up. I have a slide a little later on that kind of shows you a comparison of heart rate, blood pressure, minute ventilation, etc. But gradually it's going to rise. Your diastolic should not rise that much, and usually rises later in the exercise process as you're reaching your max workload. In healthy individuals, the diastolic should only rise about 10 to 15 millimeters of mercury, even if your systolic is at 200 or 250. Keep in mind that that is the pressure that's on the heart at rest. So people who have heart disease, that diastolic blood pressure is going to get much higher. Alright, this is a graph that kind of shows you the relationship of heart rate, stroke volume, systolic and diastolic pressure. And it really is pretty interesting and demonstrates the effects of stroke volume when your heart rate gets very high. In this case, the heart rate is starting at about 60 and going up not quite to 150. As the heart rate starts increasing, our stroke volume after a certain point starts decreasing. Why is that? Well, as long as the heart has adequate time for filling and emptying, your stroke volume is going to be fine. But if your heart rate gets too high, you're shortening that time, and you're going to have less time for filling, and therefore there's going to be less to pump out. So at a point with a higher heart rate, you will have a reduction in stroke volume. Systolic blood pressure, you see a much greater increase, and then of course the diastolic, it's pretty even, and it doesn't start increasing even significantly at all until towards later in the exercise. The bottom part of that graph represents the actual oxygen uptake in liters per minute, and it kind of shows you what's happening. We'll talk about that just a little bit more here in a minute.